complex concepts. I hope that you can walk away from this with a couple of ideas about things that you could really start to evaluate now in your practice. So moving forward, we all know that the little people that we care for and the challenges that we face with them, but when we try to quantitate those challenges, this is data that was published, and it's valuable data because it's a full regional cohort from Victoria, Australia, who were followed at 4 different epochs of time to look at survival and neurodevelopmental outcomes over epochs in the light pink from the early 90s, the burgundy from the late 90s, the purple from 2005, and the blue being 2016 to 17. And surprisingly, there really wasn't much difference in the median gestational ages within these cohorts, because the vast majority of the babies less than 1,500 grams were represented by the bigger babies. But as you can see, survival has improved over these 2 decades. Cerebral palsy, importantly, has shown us a little bit of a decline, in particular associated with the decline in cystic periventricular leukomalacia. But if we look at developmental outcomes, the presence of developmental delay or neurodevelopmental disability, you can see there's really been no improvement at all during this 2-decade period. If you add to that now recent data that was collected from the North American cohorts, and you can see here added to those graphs are the green and the reddish colors, which are the 2 cohorts that were published from the NRN from 2008 to 12 and 2013 to 2018. Again, you can see this slight trend towards improved survival, cerebral palsy rates being a little bit improved, but developmental delay being relatively static and still very common, with close to 50% of the babies experiencing some sort of developmental delay or neurodevelopmental disability. So why? Why do these babies continue, despite 2 decades of advances in the way we care for them, to have the same neurodevelopmental outcomes in terms of IVH, cerebellar hemorrhage, and white matter injury being important mediators? So let's start with those. The old causes we all recognize from the time we started training, those are brain injury. So let's start with IVH. How are we doing with IVH? Are we making any inroads in terms of reducing the rates of intraventricular hemorrhage? And you can see here, this is a 10-year data that's spread out here, and you can see that the rate overall for very low birth weight babies, less than 1,500 grams, around 1 in 4 will have IVH. More importantly, this is the data across the decade, and I think you would be optimistic to believe there was any significant difference over this 10-year period. And the same occurs for any of the absolute grades of IVH. This is the data from the Vermont Oxford for a 10-year period from 2012 to 2021 for any IVH, being, as you can see here, between 25 to 35%, and severe IVH approximately 10 to 15%. And you can see that it is really completely unchanged over this 10-year period, despite many things we've tried to do. And this was shown again by the NRN, who published data on close to 35,000 babies over a 20-year period, and showed that during this period there was a dramatic improvement in the use of antenatal steroids and in terms of trying to reduce aggressive intubation and ventilatory strategies. And despite those things that we believe should help, you can see the rates of severe, i.e. grade 3 and 4 IVH were really pretty static, apart from maybe a little trend more recently in the 28-week gestation infants. But otherwise, across the board, you can see the rates are much higher in the more immature babies, but across the board, the rates are relatively static. So why? Why are we making no improvement in intraventricular hemorrhage? Well, as you are all aware, this is a very multifaceted form of brain injury that has factors we can't really influence: how immature you are, which influences whether your brain is able to auto-regulate in terms of systemic pressure and brain cerebral blood flow, how you were delivered, whether you needed resuscitation, whether there was inflammation prior to delivery, whether there was any other types of coagulation or thrombocytopenic disorders. We can't influence those things, but there are some things we can influence, and those relate particularly to physiological stability associated with the cardiorespiratory system. The germinal matrix, as you know, is extraordinarily sensitive area that is present just during this immature period from around 10 to 12 weeks up to around 36 weeks, and that its sizes are particularly large at around 22 to 23 weeks when you have this very high rate of about 40 to 50% IVH risk. The reason it's so vulnerable is the vasculature is unique. It's very, very sensitive, thin-walled blood vessels that are very easy to rupture. And it's also a relative watershed region in the immature brain. This is a very complex diagram that Joe Volpe and I put together to try and understand the sequence of physiological changes that lead to the occurrence of intraventricular hemorrhage, and really understanding that it may be an ischemic reperfusion injury where this first phase in the first 12 hours may be associated with either difficulty immediately around the perinatal transition or with the instability associated with cardiovascular difficulties in terms of intravascular volume. And we'll talk a little bit more about that, the PDA, myocardial dysfunction, ventilatory instability, the administration of surfactant with hypocapnia, which can cause vasoconstriction, all these things leading to potentially decreased cerebral perfusion, injuring that poor little watershed germinal matrix. When these things have happened, then at about 12 hours, when the blood pressure is at its nadir and some other things have changed in ventilation and we may have been worried about a duct, is about when we as clinicians start doing things, and the things we do can cause reperfusion. So we put up treatments for systemic hypotension, we start changing things with the ventilator, we start giving various forms of treatment for the duct, and these can lead to reperfusion. In addition, we still don't have a lot of insights into what's going on with the cerebral veins, and particularly as we are moving towards more of a posterior pharyngeal pressure-based ventilatory system, what we are doing to cerebral venous drainage when we put a lot of pressure into the back of the pharynx. Regardless, that is associated, this reperfusion, with rupture of the germinal matrix. A lot of people talk about the relationship with blood pressure and that low blood pressure is associated with IVH. There is some association. We are unclear whether it is actually the low blood pressure or the treatment associated with the low blood pressure, which is our aggressive administration often of agents that can drive systolic blood pressures up much higher. And as you can see here from very carefully collected data, it's the flux that's associated with the higher risk for IVH. So you can see early in that first 48 hours, the babies tended to have slightly lower blood pressures, but then they overshot and went higher compared to the babies without IVH. So they spent more time at extreme levels. And it's this concept we now have in neonatology that flux is worse than being low. The reason that flux is bad is because in the immature brain, you can't buffer it. In the mature brain and in the healthy immature brain, you can see on the bottom level that despite some fluctuations in the mean arterial blood pressure in red, the cerebral saturations remain very stable, whereas you can see in the upper panel that when the blood pressure is fluctuating, that the cerebral saturations are also fluctuating, showing you that cerebral circulation can't buffer any of the systemic changes that are going on. IVH is often visible about 50% of the time on day one, and I actually really like doing early ultrasounds because I like to know when and what has happened. It helps me to understand whether I should be prioritizing delivery room care or care in the neonatal intensive care unit when I understand for my unit when is most of the IVH occurring. And this ranges in studies that have looked at it from 0 on day 1, and we were close to that at the Brigham, through to some units documenting 80% of the babies having visible IVH on day 1. Obviously, for those babies, one needs to look more carefully at the perinatal management. By day 2, another 35% will have begun their IVH, and by day 3, the last group have visible hemorrhage. It's rare after the first 72 hours unless there's clinical decompensation. But the hemorrhage can extend from that early hemorrhage, and 20 to 40% of the babies will extend their hemorrhage, such that the maximal extent of IVH is usually present by day 5. I have a lot of people say, oh, I'll just do one ultrasound on day 7 and look then, but you'll never understand what really happened to that baby in terms of when the hemorrhage started, when did it extend, what was its natural history. Why is IVH bad? IVH is bad because it wipes out the germinal matrix, which had important precursors for the cortex. It can be associated with white matter injury and also injure the developing cerebellum. But the two key things that really determine high risk for disability are the complications of hemorrhagic infarction or of hydrocephalus complicating IVH. So this is the consequences of any IVH, is that you destroy the germinal matrix, which was going to supply these important neurons to the cerebral cortex that are involved in more complex interneuron kind of talking to each other, and also some of the oligodendroglia that were going to make myelin. But on top of that, the presence of iron will activate inflammation in the brain, damaging the white matter. And also the blood can drift down over the cerebellum and damage the outside of the cerebellum, causing cerebellar dysmaturation. These are all going to occur without the presence of the major complications that produce severe disability. The two major complications for severe disability, as you're aware, are the venous hemorrhagic infarction that occurs as a complication of the intraventricular blood leaning on that terminal vein here and occluding that terminal vein with secondary rupture of the medullary veins, causing a venous stroke is the way I refer to it for the parents. This is a venous stroke, and you can see it here on this immature MRI. The outcomes of this are often thought to be universally poor, and I do want to caution you that just like any stroke, and the best way to think about it, it depends on the size of the stroke. So when you have an extensive stroke, whether it's unilateral or bilateral, the outcomes are obviously fairly poor, and that involves all 3 hemispheres, is what you would call extensive, versus a localized stroke, where indeed, when you look at the outcomes for these are much better than they would be even if the stroke occurs bilaterally. And this was shown again by Linda de Vries, who followed up the largest number of these babies with so-called grade 4 or periventricular hemorrhagic infarctions, or venous strokes, as we like to call them. There was 213 of them. The vast majority were just isolated in the parietal lobe. So you have to understand that in the Netherlands, if there was an extensive stroke involving multiple hemispheres, that baby would have been receiving comfort care. But if it was a focal stroke, then they would survive and continue, as many of these babies did. And of those babies who survived, only 50% of them had any degree of motor impairment, and the vast majority of those only involved the upper limb, and the upper limb had isolated spasticity associated with that. If it involved more of the frontal or the temporal, then you could be more likely to have some cognitive or behavioural difficulties that could occur in somewhere between a quarter to a half of the children. Perhaps the most devastating and the most able to be intervened in, though, is that of hydrocephalus complicating IVH. And I really want you to think about what you are doing in your own unit as you look at this data. So if you look at IVH as a whole, about half of the children with IVH will have some form of ventricular dilatation, but only half of those, i.e. a quarter, will have progressive ventricular dilatation. Of those that have progressive dilatation, about half of them will spontaneously arrest, and the duration of intervention. How do we know when to intervene and what to do? So this was a review article that we published with our neurosurgeons and neonatology, neurology, and neurosurgery together to try and bring out a guideline. And I hope that you either all have a copy of this or have integrated it into Epic or Cerner or whatever your device of choice is in terms of your EMR. You have to talk to radiology and start them to do these measurements, the thalamo-occipital diameter or an anterior horn width or ventricular index, anytime they see intraventricular blood. So our radiologists who do ultrasounds now uniformly measure these on every baby who has intraventricular blood because they are what we can plot against normative data that is known for where these babies should be. And to help that, we know that it's important because if these measurements get big, then these children will lose abilities. So this is the maximum measurement that was occurring in the neonatal intensive care unit in children with post-hemorrhagic ventricular dilatation. This is their 2-year outcome 2 years later. So you can see as the anterior horn or the thalamo-occipital or the ventricular index got bigger, they were losing consistently IQ points in all of the domains as well as motor ability. Is there data to support this observational study? Yes. A very carefully done randomized controlled trial intervened. This was a randomized controlled trial of early versus late ventricular intervention for PHVD. It took 10 years to carry out the study to recruit the babies, and they randomized them to either low threshold, they just had to be above the 97th centile, or high threshold, that to be 97 plus 4. And then they either got LPs and then a reservoir placed and then a VP shunt if it was needed. And they looked at the 2-year outcomes and compared the two groups. And what you can see here is these are with or without needing a VP shunt in the end. But there was definitely the earlier intervention group, both on motor scores and cognitive scores, fared better than the late, particularly the late who needed ventricular peritoneal shunts. And here was the number of infants enrolled and how many of them went on to have their 2-year outcomes. And you can see here that although the mean cognitive scores, which you'll note are in the mid to late 90s for these children with post-hemorrhagic ventricular dilatation, were not significantly different, but the number of children who had death CP or a low Bailey score trended towards a difference, and those with a cognitive score less than 70 was doubled in those with the late intervention. Why didn't they see more of an impact if we're talking about early versus late? Because they were all early. If you look at them on our graph compared to the data we'd collected in St. Louis, this was early and this was late. They're really hardly different in terms of how separated they are. And they were both, compared to half of the babies in St. Louis, early. You can compare this to a study that published data from North America, again looking at what they called early, based again on looking at it less than the 2 standard deviations, or late in 127 preterm babies. And this is what they found in terms of ventricular index or anterior horn width measurements. These were early and these were late. And you can see, particularly the late who needed some intervention, that the measurements on their ventricular mass, and you can plot them and see, are you in the green zone, like less than this measurement? Are you in the orange kind of zone here, where you're plotting along the orange, or have you gone out into high risk? If you've crossed the red, you're in high risk now. And if you've crossed the red and you're in high risk, then something needs to be done. And this article also outlines for you how to think about these measurements here, that you can just observe. If you go into the orange zone, you need to go somewhere where there's a neurosurgeon present who can be intervening if needed. You could consider doing 2 or 3 LPs to see if that arrests the hydrocephalus. And you do at all times need to be doing cranial ultrasounds at least twice a week to be doing these measurements and tracking them. And neurosurgical intervention can be done if no stabilization. If you're in the red zone, you need a neurosurgeon and you need to intervene. And this is a neurosurgical emergency because these kids will continue to dilate and they will be losing IQ points in association. So moving on to other types of brain injury, a much ignored brain injury is cerebellar hemorrhage, which is often under-recognized on cranial ultrasound. One, because, again, I would ask you how many of you see the cerebellum on your routine ultrasounds. Are they routinely ultrasounding it? Often not. So if you don't look, you definitely won't see it. And if you do look, it's only the larger hemorrhages that you'll see on ultrasound. And when you looked at people who've done comparisons, on ultrasound it might be seen 2 to 8%, whereas on routine MR more like 15 to 20% of the time. It's more common in the most immature and sickest infants. It can be these small punctate lesions or a larger unilateral or bilateral hemorrhage. And larger hemorrhage is certainly associated with cognitive language and behavioural difficulties, as shown here in the Cochrane review, where the absolute risk is about 3 to 4-fold increased risk for significant disability. White matter injury is the most common form of brain injury in the preterm and the most often missed, especially if there's no cysts, which now are rare in the modern era of neonatology, because most of the white matter injury is punctate lesions or just ex-vacuo dilatation from loss of axons. This is what it can look like on MRI, just these little punctate scars through the white matter, more significant punctate scars, linear scarring, or cysts. The etiology of white matter injury is also ischemia reperfusion in those first 48 hours, but inflammatory mediated injury is also important, particularly perinatal sepsis, postnatal sepsis, even the simplest of CLABSIs in terms of a staph epi, and then necrotizing enterocolitis in particular. It does relate to outcome, especially the higher grades of white matter injury, in a similar way to the higher grades of IVH relate to neurodevelopmental disability. And this is us following white matter abnormalities out now into childhood at 7 to 13 years. And you can see the deviation from typical in terms of the downward deviation for mild or more moderate to severe white matter injury, with deficits in particularly IQ, spelling, reading, and math being most affected. We know that when you affect the white matter, unfortunately, you don't just affect the white matter, you affect everything that goes through the white matter. And that is because those connections, as you could see here from Dr. Volpe's elegant drawings of the fibers, the axons, the cables were connecting different parts of the cortex and the deep nuclear grey matter in a really important way. And when the cable is lost, then the neuron in both the central grey matter and the cortex says, what's the point? I'm not connected, I'm not working anymore, I'm just going to disappear. And so you get a secondary degeneration. So that's all pretty depressing. All those forms of brain injury are all alive and well, unfortunately, with no respective reduction in the risk of them. What do we know about what we could be doing today to try and prevent brain injury? Well, there is some data I'm going to present that I hope you'll take away and think about, particularly around the domains of ischemic and reperfusion injury and neurorehabilitation. So we know that ischemia reperfusion is most likely in the first 72 hours of life, with the significant changes that are occurring in cardiorespiratory physiology. And we need to be closely monitoring everything: blood pressure, cerebral perfusion, ideally, if we could monitor this well, ventilation, particularly CO2, fluid status, and prevent fluctuations. It begins obviously with antenatal steroids, continues in the delivery room with delayed cord clamping and proficient resuscitation, and in the NICU with careful surfactant administration and careful blood pressure management. One of the things that has been shown to be impactful was this nursing intervention bundle. And many of you have heard of these types of interventions with midline head position, incubator tilted up, avoiding the head down or the legs up suddenly. But the one I want you to focus on is avoiding rapid intravenous arterial flushes or rapid arterial blood withdrawal. All of their withdrawal of blood or flushes had to be given over more than 30 seconds. And this was applied from the delivery room, certainly through the first 72 hours of life. And then after 72 hours, the blood draw one was still continued, except the only one that was changed was the prone positioning. Why do I think the blood loss and the blood volume and the draws is important? Because I can just speak from my own experience when I'm placing lines, and particularly in the middle of the night, and I just want to make sure everything's working, that we've got to remember that our baby, let's just take a 1 kilo, might have a blood volume of about 80 mils. I need to compare that to, say, an adult who may be 70 kilos is going to have around 5 litres. If I'm trying to get off that first blood, for instance, I might need blood cultures, I might need a number of other draws to be done. It could be as much as 2.5 cc's. That's about 3.2% blood volume of the preterm baby's total blood volume. If I was equating that to you and I today, that would be the equivalent of about 150 cc's. We usually take a blood donor pack over about 10 to 15 minutes, and that's about a third of a blood donor pack. So it would be the equivalent of taking a whole blood donor's pack in 90 seconds if we were to draw it off as at 30 seconds, if you get what I mean. Like if we were to draw off at the same rate, 30 seconds on a 2.5 sort of cc draw, that would be getting a whole blood donor pack in 90 seconds. I mean, it's extremely large volume to be drawing off even when we do it over 30 seconds. And you've got to remember, the baby's got limited capacity to buffer this compared to an adult. If I took off your whole blood donation when you go to donate blood in 90 seconds, you might feel a little lightheaded and you've got intact autoregulation. So I know that when I've started to do this, that I have typically in my past drawn this blood off at faster than 30 seconds. And I should be doing it at probably a lot slower than 30 seconds. But it's not what we're used to doing. And so I would challenge us all to think about whether we can start getting a stopwatch, start looking at how quickly we draw back from our lines and we flush our lines, and teach ourselves and our nursing colleagues that this blood volume is actually a substantive blood volume that we are drawing off from our tiniest babies, and we need to be doing it extremely slowly. Did it make a difference in this trial? Look at the difference. In our most immature babies, there was almost a halving of the risk of new IVH or PVL in the intervention group. And it was less impactful at the bigger gestations, 27 to 29, but still made a difference. Can we monitor the brain and see if what we're doing is bad for the brain? Well, we would love that, to be able to monitor cerebral perfusion. Unfortunately, we only have the surrogate of cerebral saturations, which are not necessarily fully reflecting cerebral blood flow. In addition, it's been difficult for us to validate our current devices. And the only trial that's been done, which I'm sure you're all familiar with, which was published in the New England Journal last year, did not show any impact of the randomized monitoring of cerebral oximetry with a simple algorithm for intervening on the rates of severe brain injury. As you can see here, that were no different between cerebral oximetry or usual care, suggesting that either the device is not doing what we think it's doing in terms of reflecting it, or because unfortunately in this trial no one recorded whether the monitor was picking up well, what was done if the monitor went low or high, despite the fact the algorithms were in place. No one documented whether the action was actually taken or not. So a lot of gaps in knowledge still about near-infrared spectroscopy before we are ready to roll that out. But we know that cardiovascular physiology is important. Do we have any other way to do this? Well, modern hemodynamics would tell us that our usual approach of standing at the end of the bed, looking at hypotension and saying, you know what, I think we should just put up some dopamine, may or may not be right. And this was certainly shown by the recent work that was published from Patrick McNamara's group, where they use targeted echo in all of their very preterm infants and compared this to a historical control group. They try to differentiate these groups by looking for small PDA, a larger PDA, pulmonary hypertension, cardiac dysfunction, for which they would start dobutamine, or obviously ruling out congenital heart disease. And what they showed with this targeted type of hemodynamic screening and targeted treatment based on the echo was that they did show a significant reduction in severe IVH with their historical controls, both for their most immature 22 to 24 weekers and their slightly bigger babies. And this was pretty strikingly impactful. If we do end up with brain injury, is there anything we can be doing? And neurotherapeutics are a long way away, unfortunately, for brain injury in the preterm, but neurorehabilitation is not. And injury often has a major impact, as you could see, on motor outcomes. And there are things we can be doing in terms of directing physical therapy that can be infant-centered, family-focused, and most importantly, that we don't drop the ball, that there's continuity with post-NICU interventions, and don't please just discharge the babies hoping that early intervention will pick up sometime in the first 3 months. Make sure that the family know how they can access all of the complex forms they need to fill in to get to their regional centre evaluation, or if they can't, how they could be following up with outpatients in your own setting. Does early intervention make a difference? Absolutely it does, and there's a new Cochrane review on the way that shows it's even more impactful. Okay. And this was a very nice study that was published recently. Okay. It is in a rodent, but it was powerfully controlled, looking at environmental enrichment, which was motor activity, social stimulation, and bright, shiny objects, so general enrichment. And they looked at a standard form of hypoxic preterm-like brain injury, and they intervened either with no intervention, just a little bit of early, like maybe NICU plus a little bit of home, or delayed after you've been home a while, or just very late, let's say school age. And they compared that with continuous or even delayed and extended. The real impact came in the continuous. Starting early and continuing right through into later school age equivalency had improvement in cellular recovery, ultrastructural recovery, and behavioral recovery. And in none of these other models did we see anything like that. So the importance of being able to offer the rehabilitation early and continuously. So my 3 take-home messages for you: draw blood and flush slowly. Get stopwatches for you and your nursing team. You might be surprised. Monitor for IVH and PHVD, and if it's present, measure on your ultrasound and intervene early. Do not let those ventricles get big and lose all those valuable IQ points. Rehabilitation is the word, not early intervention, because these children have had brain injury, and at any other time of life, we call it rehabilitation. And it should start early and be continuous. So those are my take-home messages on brain injury, but that's not where the journey stops, because we know that there's other things happening to the brains in our preterm infants apart from brain injury. And we particularly know there's alterations in brain growth and brain development. We know the brain in our hands. This 12-week period is undergoing dramatic growth and sophisticated folding. And in fact, we've been able to compare, and this is a representative image trying to capture it all, the differences between a typical term-born brain shown here on the right and a premature brain at term equivalent, showing the common findings of reductions in grey matter and grey matter folding in the basal ganglia, in the hippocampus, and in the cerebellum that we see in the prematurely born baby by term equivalent. We know the brain is undergoing a rapid period of brain growth in the NICU, and in particular from 35 weeks on to term. This is a real brain spurt time, and it's often a period that I feel like we don't take advantage of in terms of either our nutritional optimization or our enrichment optimization. We know that many of our babies don't reach nutritional sufficiency. That extrauterine growth restriction is common, and you can see here data that was published some time ago now, though, that showed the number of premature babies that are less than the 10th centile, even in the more recent eras, is close to 50%, and less than the 3rd centile is close to 25%. That nutrition early also matters, and the amount of both energy and fat, and whether that's by parenteral or enteral nutrition, and particularly the amount of protein, has been associated with both brain growth and different measures of brain maturation. So that not only are those latter phases of nutrition, but also the early phases of nutrition are really important to optimize brain development and growth. The brain is undergoing this very complex series of folds that occur from the almost oven mitt flat brain at 25 weeks through to this very complex, convoluted, folded brain. And we can take this and see that a healthy term baby has all of the tertiary folds that an adult brain has. The term brain is so complex and so well developed. And our premature babies are trying to get there, but we can compare our term equivalent, premature babies at term equivalent with our healthy term controls. And when we do that and we squish the brains of a whole lot of premature babies who don't have any brain injury against term-born babies who are at the same matched postmenstrual age, we can see that one area in particular lights up as different. So remember, these premature babies didn't have all those types of brain injury we said are associated with motor and other cognitive deficits. These premature babies escaped all of that, and yet when you compare them to healthy term babies, you can see this big difference along the temporal lobe, in particular along the superior temporal sulcus and in the dorsal prefrontal area. Now, the temporal lobe's uniquely human. It's involved in facial recognition, it's involved in language, it's involved in a lot of sophisticated higher order functions. And so we kind of thought, you know, the babies started on the back foot, give them a little time and they'll catch up. So we imaged them 7 years later, and indeed 7 years later, we still saw this dramatic difference between premature babies and term-born babies. So we've now tracked these children over 13 years, and actually it's a little bit scary because not only is the difference still there, but the difference is getting bigger. So here they were on the far left at term equivalent. Here they are at 7 years, the darker blue highlighting the area of maximal difference, and here they are at 13 years. And you can see this here in their trajectories, which have individual trajectories for the 222 premature babies and the 100 controls that we mapped here, the term controls in blue and the premature babies in orange. And you can see that the gap between the two curves is getting bigger. And this is concerning because this area is an area that is prone and vulnerable to aging. And so to start with reduced reserve and potentially reduced resiliency in this region, we are worried may not bode well for aging in our preterm population. But regardless, the difference, as we showed you before, was present at term. It's present and established by the time they leave the neonatal intensive care unit, and it has consequences right throughout their life. So why? Why is the temporal lobe affected? What's going on? Well, we had a medical student who was taking a year off, and she said, all your babies are so stressed. And I can't say that I had really thought about it or really realized it. And so we developed this thing called the Neonatal Infant Stressor Scale, which was characterized by our 240 of our nurses as to what stressed babies out with a weighted scale. And then we measured over every 12 hours what happened to every single baby in this study. And what we found was there is quite a lot of variation, but overall, the first 28 days are very stressful. This equates to about 10 to 12 painful procedures a day, every day for the first 28 days of life. Interestingly, there's enough variation between providers that we could untangle severity of illness and other things and show that the more stress they had, the more impact they had on the temporal and frontal networks. And this was even after adjusting for immaturity, length of ventilation, crib score, sepsis, everything. Nothing impacted this. We've known that ways of modifying stress in our babies by kangaroo care can be extremely impactful. And this was a beautiful Israeli study that randomized to just 1 hour of kangaroo care each day for 14 days in one group and matched controls in the other who didn't get it, and showed improved development by the time they left the hospital and through the first 10 years of life. We've also known that there's a big change come in our own neonatal intensive care unit environments where because we thought we would want to reduce stress to our babies and families, we'd make them all into beautiful Hilton hotel rooms where our babies would have the wonderful stress-free experience of a quieter, less stressful environment. And so when you compare overall NICUs with and without infant rooms, as is shown here, you can see apart from perhaps a trend towards a reduction in length of stay, there really wasn't any benefit that was potentially seen. And in particular, I just pay your attention to IVH did not show any improvement, and if anything, a slight trend up. So when we studied this to say, gosh, is those beautiful, quiet, single rooms the answer to helping us in terms of the brain development and outcomes, and in particular this temporal lobe that might be so sensitive, this is what we found. And it was a shock because we thought the private rooms would be beautiful and really help reduce stress. But what we found was that the private rooms were associated with a 7 IQ point deficit, which after correction became 8 IQ points. In language only, but also a strong trend in motor development to impairments in the single room environment. And we were like, what the heck happened? The single room environment was going to reduce stress. It was going to be better for the brain. The babies were all going to do better. So we studied the brains, and when we looked at the brains, what you can see on the left here in a total normal term baby is hemispheric asymmetries. In red here, it's deeper on the left, and this is the language, that superior temporal sulcus region, the language area. And in blue, it's deeper on the right. This is facial recognition. Now, in the open ward, the baby's trying. They're trying to form these hemispheric asymmetries. In the private room, very little to no hemispheric asymmetries. The room environment they were in had influenced brain development. Why? So you have to understand that what is happening in the neonatal intensive care unit is very different to what would have happened if the baby had been carried forward in its pregnancy. And this was defined by a postdoc and then a young scientist who worked with us initially in Boston and then went back into Illinois and Missouri to study this. And what he showed was by using the Lena devices, this is what a fetus should be exposed to. Around 2 to 3 hours of adult language every 24-hour period. This is what a premature baby in an open bay neonatal intensive care unit is exposed to on average, about half an hour worth. But they are exposed to a lot more electronic sound and airborne noises. Interestingly, the diurnal rhythm is also lost. Here is what happens in a normal fetus. They get it from the time mum gets up all the way through the night until she shuts down for the night. In contrast, in the neonatal intensive care unit, there's a little bit more during the day, but it's pretty flat. Quiet for the baby overnight, and then during the day they get sound, whereas in the NICU, 24/7, it's up. Are there differences between the two room environments? Could this explain our difference in language development if the babies were getting different language exposures between the private rooms and the open bays? And what you can see here overall is LENA data that was collected in the same unit that study was done, comparing private rooms and open bays for what we call meaningful language, which is I'm talking to the baby up close and asking them how their night went and what's going on. You can see on average over the entire time up to the time that they were term, these babies, on average, the amount of time they got with meaningful language was pretty low, and it was not very different. But if you look at the time with distant language, i.e. were they hearing nurses in the background chatting about what they'd watched on TV last night and other such things, that there is a striking difference between the two room environments, with the private room having significantly less distant language exposure compared to the open bay. So the private room environment here was significantly lower. And the electronic sounds were significantly more than often the meaningful language. And again, there was a difference with the open ward having more of the electronic sounds. So both Betty Vore and I have been studying this for some time, and the message that we both really want to send is it's actually probably not the room environment, even though the single room environments do increase the vulnerability for sensory deprivation. But it's really who is in the room that matters, whether it's open bay or single family room. It turns out who you're with really matters rather than the room type. So do we have any data about our parents and who is at the bedside in terms of how often our parents are present and whether they're holding and what we know about that? And this is, if you just look at the hours visited birth to term here, you can see on average that the interquartile time for hours visited per week was between 10 and 20 hours per week. So that would be around 2 hours, if the median was 14, 2 hours a day that on average the parents were present. Days visited per week, on average, 5. Days cuddled, on average, 2. Days skin to skin between birth and term, 0.3. Day of first hold, 5. So this is data now that is about a decade old, and I know many of you, particularly in California, have been working on this, but I would say our experience, and we're about to start collecting this data again at CHOC, is that on average, I don't think our parents are present for more than 2 hours a day. So we know the environment is influencing brain development. We can see it on this observational data. It's clear that noxious stimuli are common, as you could see from the recordings that I showed you. Alarm noises, bright lights, variable handling, and that there's often an absence of nurturing and enriching. And you can see that by hours presence and days of holding. Have you evaluated this in your unit? Do you have any data in your unit about what your parent presence is like, what your parent holding is like, what your noise, what your meaningful or distant language recordings are like? Because there are ways to be able to intervene. There have been a number of studies looking at interventions such as music, singing, maternal voice. And the treatment lengths have varied 45 seconds to 45 minutes, 1 to 4 times a day, 1 day to 21 days. They have often all shown positive impact, many related to improved feeding and less parent stress, but also one study with maternal voice, fewer stress responses, better neurobehavior, and better neurodevelopmental outcome. So we have to understand this environment is more than just room type, but room type is one modifier of it. It's speech, human speech, it's noise, it's family presence, it's light, it's touch. because these things are really forms of social deprivation. They disrupt hormones, they increase stress and inflammation, and they alone can also lead to cardiorespiratory instability. And the number of parents who'll tell you they don't spell when they're, having skin to skin with me. These things are all impacting neurodevelopmental outcome. So why aren't our parents fully engaged? Well, another important study was led by Leanne Woodward, who interviewed 300 parents in Boston. And what she found is not dissimilar to what others have, that around 60% of our mothers and 40% of our fathers left the NICU with some form of psychological distress, depression, anxiety, or PTSD. This is well known. It's been shown in other studies between 15 and 63% of mothers compared to 10 to 15% of term-born. Anxiety in particular is very common in mothers of preterm infants, and it does not get better when they go home if it is not addressed. So you have to think in your own unit, what recognition and engagement do you have about this particular issue? Are you doing any screening and intervention? Do you normalize in your discussion with parents mental health needs? If you have got a single family room unit, do you have group therapy? Because peer-to-peer can be extraordinarily valuable, and it was native in the open bays, but having separated all of these families, we've lost a lot of that. And finally, I'll say for all of you that caregivers also experience trauma, and we need a program of care and support for our own mental health needs. Paid parental leave is something that the US should be somewhat ashamed of. We join Lesotho, Swaziland, and Papua New Guinea as the only countries that do not mandate paid maternity leave. And most countries ensure at least 3 months of paid leave. We know many of our mothers who get this, particularly in California, will defer it till the baby comes home. But there are governments around the world now who offer additional preterm baby payments that allow parents of babies born preterm to access additional leave payments to a maximum of 13 weeks, depending on the gestational age. In Canada, there's a 15 to 18 weeks of paid maternity benefit to the parents of critically ill children, and they can have that and have found that the parents experience less financial stress and greater success returning to the workforce. So here are my 3 take-home messages on brain development, and an extra big one for us. You need to feed the brain nutrition with protein and calories from day one. Maternal milk needs to be supplemented, and ideally, we don't know yet, but we think measuring human milk by analysis and individual fortification makes more sense. You need to look at your environment, measure parent presence in infant holding. It matters, and it's important to understand where your unit lies. What is your environment, auditory environment like? Parent mental health has a long-term impact. Talk about it and create programs of care. And finally, the big one, we could all advocate for our parents to be with their baby. Here in California, we have a government that wants to listen. We really could be out there allowing them, along with the other programs that are supported, to adopt this. So how can we improve outcomes? You have to think of this in 3 different buckets. You have to think of the biggest vulnerability to brain injury being that first 72 hours, and being able to think about monitoring the brain in the future. But at the moment, just think about cerebrovascular physiology. And if there's one thing I'd implore you to do, it's thinking about how you could draw bloods and monitor that. You have to think about brain development in the next epoch. What are the negative experiences? Are there positive experiences? How are you nourishing the brain? And then obviously, as our parents and children go home, how can we think about the medical care of our babies, the parents' emotional well-being, and the rehabilitation services they may need? Think about bedside monitoring. Think about getting a stopwatch. Think about what your neuroimaging protocols look like. Are your cranial ultrasounds really being done often enough? Are you getting measurements in any baby with IVH? Have you got this protocol for post-hemorrhagic ventricular dilatation that plots these things and gets interventions? Do an environmental scan and consider any interventions. Do you work with your therapy team to make sure the rehabilitations and therapies are integrated for our babies? Think about a parent program that can support the parents, particularly during this time of anxiety, and a peer-to-peer type of program if you're particularly in a single family room environment. And think about educating our staff around all of this data, because if they don't understand why, then they won't partner with us effectively to really try and optimize the environment for our babies. Because to improve neurodevelopmental outcome, as they had the privilege of publishing with Joe Volpe and Peter Anderson last year in the New England Journal, it's a complicated thing where there are many factors. It's not going to be a single magic bullet, but we can make a difference, and we can do this by advocating for the things that need to be changed. Because for the last 20 years, we unfortunately have been stuck. So with that, I know how much we are all here because we care about this, and I appreciate greatly your attention, and I'll stop there in case there are any burning questions.
Thank you so much. That was an amazing, awesome amount of information in such a short time span. Very comprehensive. We do have a few questions rolling in. I'll just read out the first. Are there any studies, perhaps specific studies, looking at parents who read to their babies in the NICU and their outcomes?
That is a really good question. As some of you may know, many units, along with our own at the Brigham, started the Baby Academy. We did it for two reasons, and I love reading programs for two reasons. One, it can empower parents to have a specific role. You'll often hear parents say, I don't know what I'm meant to do when their baby is small. And having them be the only people that can read to their baby makes them have a very defined, specific, special role. So it empowers the parents, which helps, I think. In addition, it's meaningful language. And you could see on average in the WashU study, we had 6 minutes of meaningful language a day, 6 minutes. The babies are definitely meant to be hearing more of that, particularly from, 28 weeks on. And so we have still got a lot of work to do in trying to understand which sensory inputs at which time are developmentally going to be best. But I particularly am enthusiastic about reading to the babies from 28 weeks on for at least 20 minutes a day.
28 weeks, 20 minutes a day or more. I also noticed that there was a recording of 5 minutes that was helpful in one of your slides. Could that be an alternative for those parents who can't come in or perhaps have limited access?
Yeah, isn't it sad that here in the United States, our immediate default is to go to, well, we'll never get the parents there, so let's just record their voices and put it around the baby because that's the best we can do. I would love us to do more. I would love us to become the champions to advocate to get paid parental leave for all of our parents of our babies in the NICU so that they can truly be. There is nothing like the presence of the parent holding and talking to their baby. If they cannot be ever there because, they've got 3 children up in the desert for us and, getting down here 2.5 hours away is impossible, of course, but those are often the parents that don't have access to other devices to be able to record their voices. You've really got to have a program that does this well. And I think the problem is sometimes people who have dabbled in it have not done it with appropriate and guided programs. We have a music therapist here at CHOC who does record our parents either reading or singing to their baby, and we'll put it against sometimes the parent heartbeat and really filters out some of the harsher types of frequencies so that the baby has an appropriate type of auditory experience. So I try to veer away from just random recordings of anything being popped into the baby's bed to make it more scientifically a little bit robust.
Thank you. That was, you've jumped ahead to one of our other questions here about music therapists in the NICU and how to best utilize them. We've got another question about, families and children and being pulled in different directions, especially in the winter months when respiratory season is here with us. Children are not allowed, so that also leaves the parents maybe at home. Any strategies you've known or used in the
Yeah.
past?
I mean, I would love to have sibling programs available in all, or, I mean, when I think about a children's hospital like we are, the fact that we can't have some sort of daycare provision for all of the families associated with the care of the critically ill babies that we have in our facility is it's kind of something we should be ashamed of in some ways, that we just don't have that, because then we could have our parents be present without having to be worried about the fact that their babies or other children were getting appropriate support. It is challenging, I understand, and I think, one hopes that you've got two parents and that both parents can have supportive employers that understand that one parent may need to be at home looking after the other children while the other parent's at the NICU. I mean, these are all real life challenges, but I often think, we if we could just get paid leave for them, and the expectation was that the parents were present. I don't think our expectations socioculturally, and I see Bob White's on here, so maybe he can speak to it as to whether he's had more success. I don't think our sociocultural expectation of our staff or of our broader environment is for our parents to be in the NICU. And yet, if they go home and then they get readmitted 3 weeks later to the pediatric floor, if the parents put their baby down and said, "Oh, bye, I'll see you tomorrow," I mean, most of the nursing staff on a pediatric floor would look at them as though, like, "Excuse me, where are you going? Like, what's going on here?" It's just a very different sociocultural expectation. I don't quite understand it, but it's real.
Absolutely. And you're absolutely right. Shame on us for this. We are working very diligently at the AP level, particularly from the section in the Women in Neonatology, to push for paid leave. You've provided me with a lot of ammo to add to our thoughts in our fight here. I want to just go back to a few logistical questions and also your thoughts on maybe the prevention or the early neuro rehab side. We have some questions about optimizing nutrition. What is the max calories you may be comfortable using, and at what point would you switch over to protein to be additive? And also your thoughts on Indocin as IVH prevention.
Yeah, so I think the Anderson story, I really truly believe that the way we should be going is targeted hemodynamic knowledge. We shouldn't just be throwing Indocin around without knowing what we are treating. And I think that's what is so elegant about Patrick McNamara's work, is showing, and I hear all the time from people, I hear this about cranial ultrasounds, "Oh, it's another aggressive thing you're doing to the baby. We're trying to have hands off for the first 72 hours. You don't have to be aggressive to put an ultrasound probe on the fontanelle. You have to have dedicated ultrasound technologists who come into your unit who know how to we're not trying to do a massive ultrasound. We're just trying to have a quick look to see if there's hemorrhage there." The same with targeted echo. It's not a whole echo. It's targeted echo to look, is there a big duct? Is there pulmonary hypertension? Is there poor volume? Is this baby volume replete? Or do they need additional volume? What am I going to target in terms of managing hypotension if hypotension is present? And so I really believe we shouldn't be just throwing substances anymore. We should be making sure we advocate and get people trained to be able to do targeted echo and looking after these little tiny babies. In terms of nutrition, it's a balance. Don't we know that with everything? I think, we know that maternal milk is extremely powerful. I still don't know whether all of our data shows maternal milk is associated with improved neurodevelopment. I don't yet know whether it's the maternal milk or whether it's the fact the mother is present is so tied to the presence of maternal milk. If the mother is present, we get maternal milk. If the mother isn't present, we don't get maternal milk. So when I look at the association of maternal milk, what I'm really using is a surrogate almost for maternal presence. And I've never been able to untangle those two to know. But regardless of that, obviously optimizing parental nutrition, starting with maternal milk. And then I really believe, I do believe, and we don't have the trial data yet, but I do believe that individualizing nutrition by measuring the constituents of human milk, whether that be donor breast milk or maternal milk, by knowing how much protein calorie you're giving and being able to adjust it with protein supplementation or additional. I don't use MCT oil, but we do use either carbohydrate or additional protein supplements. And you have to look, please don't just look at your baby's weight. It drives me crazy that everybody just looks at weight. Could you please look at length and head circumference? Because you'll see your babies will be gaining weight, particularly on things like prolacta, but they won't be growing in length. They're not getting enough protein. And it's just, you've just got to add some protein in. That's been our experience anyway. And I like keeping protein going, additional 120% protein calorie intake I will regard for the babies with significant brain injury through the first 6 months of life. And I regard nutrition as part of neuro rehab.
Absolutely. I want to take the opportunity here. We've got a few more questions, but to have Bob White maybe unmute himself and then give this comment out loud. He wrote a bit in the chat here. He's got a very unique situation and setup over where he is at. Oh, do you want me to unmute you, Bob?
Thank you, Clara. Can you hear me?
Yes, absolutely.
Terrie, this was terrific. And for those who might not know, Terrie's model that she developed in Boston of an open room for feeder and grower babies, where they got this multisensory stimulation that might not have otherwise been available in private rooms, is a really good model. So private rooms are important if families are there so that we can facilitate that. And some of our families are wonderful in that regard. But if the families aren't there, a private room just becomes an isolation room. And we either have to deal with that ourselves with nurses and volunteers and therapists providing that stimulation, or we need to put them into a multi-bay room with other kids so that they can get this stimulation, as Terrie showed. I think, Terrie, your data was from St. Louis, right? And it was a relatively inner city population, as I recall. So there may be settings where private rooms work pretty well if families are going to be there a lot. And there are other settings where that's not the case, but most of us are in the middle, where some families come and some families don't. And we need to do a much better job of filling in for the family to provide that stimulation than what most of us are inclined to do.
Yeah. And
I totally agree. Totally agree, Bob. And yes, the St. Louis population was very much a hybrid inner city and also privileged population, but it was a hybrid. The Brigham population, interestingly, the data was not as different as you would have thought it would have been in a more privileged population of Bostonian families. We found similar distribution of the auditory environment, particularly in the single room recordings. And all of it deviates a lot, as Brian Monson showed from his Kansas City data. Deviates a lot from what the fetus would have experienced in utero. So a lot of opportunities. And I think, people have probably heard me a little bit. I have a personal problem with the incubator box, the box. I find it very suboptimal in terms of its design for brain development. But we've got them in another box, if we haven't got anybody taking them out of the box and having nurturing experiences with them. And we just have to be aware that that's what we're doing, as Bob said.
I'll just finish off with two questions. I hope this might be a quicker one, and then we'll do a longer one about logistical question on the flushes. Is there a possibility to make them too slow?
I'd encourage you all to start. When I started doing this, I thought I was pretty slow, actually. I was kind of shocked when I actually started looking at what I actually do. We're pretty fast. We're just speedy people. We pride ourselves on how quick we are. That's what we do. We pride ourselves on how fast we go. And so, yeah, of course, I mean, if you're doing it over 10 minutes, you could clot in the line and, that would be terrible. But, just try around 30 seconds and see how it feels awkward to start with, because it's slow. It's slow.
Seems slow. And then, is there criteria you might use to perhaps consider treating these very preterm infants for low blood pressure or hypotension just within that tenuous initial 72 hours?
Yeah. So what is the magic number for any baby? The problem is that we don't know. I'm a big believer that I don't try to jump in on every baby when their mean arterial blood pressure is at their gestational age. If the baby looks pink and they're moving and they're passing urine and they look good and there's no other reasons for them to be in shock, I will sit with it, because I know at 12 hours they're going to reach a nadir. And the last thing I want to do, and I've done this because I've seen the dopamine go up and I see what happens to their systolic pressures. And believe me, if you look not at their mean values, look at their systolics and look what happens. And that dopamine is going in through a central line that has many other things going through it that ebb and flow. And just watch what happens to those systolics as they peak up and down and up and down. It is freaking scary. So that stuff is not, we don't have dedicated lines like almost everybody else who gives dedicated inotropes does in a cardiovascular setting. We don't. And so we have to be realistic that it's risky. And what's the risk benefit if you've got a baby who's just teetering on a slightly low blood pressure but looks good, versus putting up a substance that is going to have ebbs and flows and produce hypertension potentially in the systolic domain at least. I don't have a magic answer for you because I think every baby is going to be different. And it's part of the problem with these trials where we've treated everybody as though they're the same. They're not the same. They're all different. And that's why this individualized care model has got to start to be evolving, I believe.
So because of time, I'll end us there, and maybe we'll email, if you don't mind, these last few questions. Thank you so much. You've given us not only a fantastic physiologic overview, but like very concrete tips that we can do on a daily basis. So thank you. I hope we see you again.
Yeah, and I really hope, at least for PHVD, it was shocking coming to California and seeing no one does any measurements on cranial ultrasound, let alone does many cranial ultrasounds. So at least please look at that data, and please, the next time you have an IVH, make sure those measurements are being done in all your babies to track those and to intervene in a timely way, because those are low-hanging fruits of IQ points you can be saving in our babies.
Absolutely. Thank you so much. And thank you everyone for joining. We would love to see you next month. We'll be here on the 3rd Tuesday of March with Dr. Ravi Patel. He'll talk about transfusions in our preterm population. So we're staying on the preterm topic here. So thank you, Terrie. Dr. Terrie Inder, again from CHOC.
Thank you guys so much for your attention. Thanks, Bob, for joining. I really appreciate you and all your leadership in every way that you've given us for so many years. I hope you have a wonderful time if you're on Ireland.